have a case to be presenting diamonds in the rough. This was a 78-year-old male. He had an old inferior wall MI. He presented to us with a shortness of breath, function class 3. Echo showed some mild LV dysfunction, akinetic scarred or RCA territory, moderate AS, mild ARs, and some moderate TR. We did a coronary angiogram for this patient. LCX to OM showed 90% stenosis, and distal LCX was occluded. LAD proximal calcific disease, 80% stenosis, and RCA proximal to mid was 90% stenosed. Now the coronary angiogram showed a calcific triple vessel disease. We took a CTVS opinion. The patient was turned down because of very low BMI. He was elderly, he was frail, and we had initially anticipated he may require aortic valve replacement also. But upon assessment, the LV gradients were low. It was around 18, so it was mild AS. So the family was counseled for CHIP PCI, and we had initially planned for rotational atherectomy. Our initial plan was stent to LCX, followed by left main LAD, and rotation atherectomy to both vessels. We took a 6 French sheath, we took a PB3 guide, Sion blue wire with microcatheter, 1.5 millimeter rotabur used at LCX and OM. As you can see, the rota had caused a perforation at the OM, but the hemodynamics remained stable and the perforation itself was small enough, so we initially ignored it. But as we progressed, the patient had mild hypotension, not significant, but mild hypotension, so we did not want to risk it. We gave 2-minute proximal balloon tamponade, and this had sealed the perforation. And then we took a 2.538 stent to the OM, and once deployed, we saw some underexpansion in the proximal part, which was then treated with a non-compliant balloon, and a guide liner was used to deliver the non-compliant balloon. The balloon itself had corrected the underexpansion, but we had a second complication at this point. We had seen, now there's a left main hematoma. Now we are in a pickle. Now what can we do? Options are fix the left main. That leaves us with a problematic LAD. We can skip the rota in the LAD and manage with a cutting balloon, risk underexpansion of the LAD stent. But ultimately, we finally decided to follow up with the rotational atherectomy to LAD and then DK crush to LM, LAD, and LCX. So the rota to LAD we did with 1.5 millimeter burr, and then post-rota D1 had slow flow. We did POBA to D1, and then the flow was restored. But then immediately after that, LCX was shut off, LCX was rewired. And then we did an LM bifurcation with the DK crush. Proximal LCX was stented again with 2.7518 stent. And then LM LAD with a 313 stent, and kissing balloon with 3.56 and 2.58 non-compliant balloons. And for port, we used a 4.56 NC balloon. Check angiogram, TIMI3 flow was achieved. Final result we had achieved was good. So take-home messages: patient selection defines the battlefield. The patient was already turned down for surgery, and therefore we had to roll up our sleeves. Plan for complexity and escalation. We had to, take all possible options into consideration. Every device choice should have intent. We have to know what we are supposed to, why we are taking, and what result can be achieved by that. And flexible strategy. We should be flexible with our strategy, not with our principles. A planned LCX, OM, and LAD, LM can be achieved even when under pressing conditions. And planning, patience, and perseverance are keys to success. Thank you very much.